Hello, welcome to my OB-GYN Success Lectures. My name is Roshan Burns. I'm a medical student at the University of California, Irvine School of Medicine, and I created these podcasts as a way of introducing third-year medical students to the basics of OB-GYN knowledge before their OB-GYN rotation starts. When you start your OB-GYN rotation, you'll see that there's so much new information, terminologies, procedures, and all these expectations of what you need to know, even though this may be the first pregnant patient that you've ever worked with. So I wanted to create a series of podcasts that are hopefully very brief and can be watched like the night before your rotation begins to just give you the briefest introduction so you can succeed on your first day of OB-GYN. So with that, this first lecture, which I've arbitrarily chosen to be first, is the labor and delivery basics. I have modeled this after our experiences at UC Irvine Medical Center. I know that our students rotate elsewhere and then other hospitals might operate slightly differently, but this is just going off of how things run at UCI. When a patient comes in for rule-out labor, she's taken to the Obstetrics emergency room, or OBER or OBEV. It's constantly changing. And this is where she gets triaged. So that is where the medical students come in most handy. We go and we do the triage. We take the history physical. We look at the fetal testing and ultrasound, and then we report back to the residents to let them know who's in the OBER and what stage of labor they might be in. And then further on in this talk, I'll talk about what happens after the OBER triage, which is like the progression of labor, and then also briefly touch on postpartum care. So all OBER patients will start with a history. So this is just your initial triage. You're trying to figure out where this lady is. Some of them will be coming from our clinic. Some of them will be coming from private offices. So you may or may not have their background OB notes. All histories should start with the following format, which I'll fill in. For example, a 27-year-old G3P2 at 37-2 presents with the following. And then you will confirm the following elements of the patient's history. So you're going to investigate whether or not they have vaginal bleeding, vaginal discharge, loss of fluids, contractions, and whether or not they know their group B strep status, GBS status. So with vaginal bleeding, that's pretty straightforward. We never really want any woman to have bleeding for her vagina. She may have slight bleeding, just bloody tinged urine or something like that when she presents, but frank gross bleeding is a sign of possible placental abruption, placenta previa, and requires further investigation. Vaginal discharge can be pretty normal with progression of labor. It's normal to pass the mucus plug prior to delivery a couple days before they may present, and then some women will present just because this occurs and they were not expecting it. But a mucus plug should be clear mucus, it should not be thick curdled, and it should not be malodorous. And then loss of fluids is termed rupture of membranes, and this is when the amniotic sac ruptures, and so there's different terminologies for when this occurs. So many women will present to the OBER without actually having a rupture of membranes. But if their rupture of membranes happens spontaneously, it breaks unassisted, that's called SROM or SROM, spontaneous rupture of membranes. If you have a premature rupture of membranes, this means that the water broke before contractions or labor actually started. So normally you would have contractions start, and then contractions would break the bag of water, and then progression of labor. But if the bag of water breaks first, then this is called PROM. Now, PPROM is called premature rupture of membranes, and this is when PROM occurs before 37 weeks of pregnancy, so the baby is still preterm. And so this is when it gets confusing, because it's preterm, premature before contractions start, rupture of membranes. And then we also talk about contractions a lot, because this helps us know where a woman might be in her labor progression. So basically we ask, when did it start? How long has she been having these contractions? How frequent are they? How long do they last? And contractions every 5 minutes indicates active labor. Women can start having contractions like 30 minutes apart. This does not mean that they need to stay in the hospital for 10 hours while their contractions become more regular. They can go home and return once they become like 5 minutes apart. And then it's also important to know whether or not the contractions are regular. Regular contractions are more indicative of labor, and then irregular contractions can be a sign of false labor or Braxton Hicks contractions. These are also confirmed with a vaginal cervical exam, because Braxton Hicks contractions will not cause cervical changes, whereas true labor will cause thinning and widening of the cervix. And also just important to check where a woman is feeling her contractions, especially if she's nulliparous and this is her first time going into labor. Normally contractions are felt like band-like in the lower abdomen, very similar to strong menstrual cramps. And so they can also feel pressure in their back and in their pelvis as the baby descends. And then just a note about GBS status. So most women, like I mentioned in the clinic success videos, will be tested at 35 to 36 weeks, and this testing will remain accurate for about 5 weeks. And so if the woman was tested positive, the patient should be given penicillin G pretty much when she arrives to the L&D floor, because it's ideally given a few hours before delivery actually occurs. So next I'm going to talk about the cervical assessment, which can kind of also better indicate how far into labor we have gone. So the cervical exam tests three things. It tests cervical diameter, which ranges from 0 to 10 centimeters, cervical effacement, which assesses the thickness of a cervix, and fetal station, which measures where the baby is in its descent into the pelvis. So to start with cervical diameter, basically, like I said, it's 0 to 10. Closed is 0, maybe 1 centimeter. Active is once the cervix passes 5 centimeters, so it's 6 centimeters and above. And then fully dilated is 10 centimeters. Thickness or effacement is basically measured in terms of percentage normally. So this is 100% effaced is there's no cervix remaining in the way of the baby's head. 0% effaced is what you would normally expect. So it's full thickness cervix. And it can also be expressed in centimeters, but that's less often used. And as you can see here, this is like a not effaced at all cervix, and then this is fully effaced. It's barely there cervix. And then fetal station is a measurement of the fetal descent, like I said, and this is measured in terms of where the baby's head is in relation to the ischial spine. So -3, baby hasn't moved down at all. And then 0 station is when the top of the baby's head is at the ischial spine. And this is all felt because when you do the cervical exam, you can feel the top of the baby's head and you can feel the ischial spines lateral to the vagina. And then once you hit 0, the fetus is considered to be engaged. This means that you can actually, if the bag of water has not been broken, you can artificially rupture membranes, AROM, from this station and beyond. If you do it before 0 station, then there's a risk that the baby is so high up that the umbilical cord can actually slide underneath the baby's head into the cervix, into the vagina, and cause umbilical cord prolapse, which is really bad. So we wait till 0 station when there's less room and ability for the cord to slide under, and then you can AROM the patient. And then +3 station, the baby is maximally descended and crowning. Normally -3 and +3 are not actually used because they are the most extreme. So when you're normally talking about the cervical exam, it's between -2 and +2. So just to give you an example, here's an example assessment. Sterile pelvic exam showed 570 and -2, or 570 -2. This just means that the cervix is 5 centimeters dilated, 70% effaced, and the fetus is at -2 station. So next thing that we assess when a woman comes to the OBER is she's automatically put on fetal heart rate testing and basically starting the non-stress test. And this measures fetal heart rate and also as it compares to potential uterine contractions. There'll be fetal heart rate tracing and uterine tachometry, which will measure the uterine pressure and which changes with the contractions. So initially, fetal heart rate tracing is done just with an external Doppler that's placed on the woman's belly, and then the uterine tachometry is also used with an external monitor. And as labor progresses, though, the external Doppler may become inaccurate and not pick up the fetal heart tones adequately. So we can place an intrauterine device called a fetal scalp electrode, FSE, and then this can read the fetal heart tones more accurately from inside the uterus. Likewise, if uterine tachometry becomes inadequate externally, we can put an internal or intrauterine pressure catheter, an IPC or an IUPC, and this can be used to quantify contraction strength from inside the uterus as well. So the NST, or non-stress test, is just our first initial assessment of how the fetus is doing. Basically, we are looking for a reactive NST, which means that there's a normal heart rate and positive accelerations. A non-reactive NST means that it didn't have a normal heart rate or it didn't have enough accelerations, and then this requires more monitoring. The first step would be to use vibroacoustic stimulation, which basically they just play a loud sound external to the mother's belly, and they try and wake the baby up. They can also try moving around, drinking some orange juice, getting some sugar into the bloodstream, just to get the baby a little bit more active. So fetal heart rate tracing, like I said, measures the fetal heart rate, but it's a little bit more complicated in terms of what we're actually looking for. So we are looking at baseline heart rate variability, presence of accelerations, and presence of decelerations. So baseline heart rate, like I mentioned, is 110 to 160 beats per minute. Now we also want the heart rate to be variable. A flat line at 150 is not a good sign. We want variability in the heart rate. And so this is considered like to what degree is the amplitude of the heart rate falling and rising with each peak. So it's not just like, oh, look, there's great variability here. That's actually an acceleration. We're talking about all these slight little bumps that we have here. This is some good variability. Presence of accelerations is any abrupt increase in heart rate, and presence of decelerations is any abrupt decrease in heart rate. So variability, basically you can have absent, which is just a flat line. You can have minimal, which is almost a flat line. There's some little flutters, but it's less than 5 beats of variability. Now normal is considered moderate variability. So the tracing shows a change in amplitude of 6 to 25 beats per minute. Marked is when the tracing is over 25 beats per minute, when you can't really tell what's an A cell versus a D cell versus baseline, and that's also not necessarily a good sign. Now, accelerations are measured to target 15, 15, 2, and 20. What does that mean? So we want an increase of at least 15 beats per minute, lasting for at least 15 seconds, 2 times within 20 minutes. So this is basically, it's not just a carrot top peak, just really fast and back down. We want slightly sustained, about 15 seconds long, and then coming back down. And it should be occurring at least twice in 20 minutes. So this is a good reactive NSD. We don't see any D cells here, and we have good moderate variability as well. If a pregnancy is earlier, the A cell may not be sustained as long and it may not peak as high. So we're actually looking for at least a 10 beats per minute increase for 10 seconds instead of 15. So just remember 15, 15, 2, and 20. It's not that intuitive. I'm sorry. So then the next thing we look for is also presence of D cells. So while we're actually hoping for presence of A cells, we don't necessarily want presence of D cells, but not all D cells are created equal. So an early deceleration is usually due to head compression. It's quite normal and it's benign. Variable D cells can be due to cord compression, and though they're not great, they're minimally concerning. The late D cells are when it gets bad. So this is due to placental insufficiency, and that's not a good thing. If we're having repeated late D cells, this could be considered a non-reassuring fetal heart rate tracing and be indicated for progressing labor more quickly or even C-section. And sinusoidal tracings are basically, there's no longer A cells, D cells variability. It's literally just a sine wave, and this indicates fetal anemia, which is always really bad. And so just to remember this, people use the acronym VEAL-CHOP. So VEAL is the acceleration type, CHOP is what it means. So variable equals cord compression, early equals head compression, A cell equals okay, and late equals placenta, and that's not good. So just to go over what these actually look like on the fetal heart rate tracing. So early D cells, like you can see here, mom's contraction, the peak of the D cell is either right with or slightly before the peak of the contraction. And we have it again here, and they're pretty consistent and regular. Variable D cells, it's just doing what it wants. It's not really matching contractions very well. So first it's early, then it has nothing to do with the contraction, then it's late, so it's all over the place. Late D cells are consistently after mom's contractions, and that's a sign of placental insufficiency, and once again, late D cells are bad. So the next assessment we use when a woman comes in is ultrasound. So normally at the very least, we want to ultrasound the mother's belly to test for fetal presentation. So basically is the fetus's head down or up? And then if indicated, we can also use the ultrasound to test for amniotic fluid index or AFI. So this is normally used if there's signs of fetal distress on the fetal heart tracing, the pregnancy is past term. Also, it can be used to assess for if the contractions are determined to be irregular or false labor. Sometimes that's a sign of dehydration, and so we want to check the maternal amniotic fluid index as well, just to check that baby has enough fluid if mom's dehydrated. So to perform this assessment, you're going to take vertical measurements like you see here all over mother's belly. So you're going to divide mother's belly into 4 quadrants, just like we do on an abdominal exam, and you're going to find the deepest pocket of fluid in each belly. So like you see, so the deepest pocket, it's going to be straight vertical. So even though this may be deeper or this may be deeper going diagonal, we want straight vertical pocket right here. And then you also want the pocket to be clear of any cord. So if you're not sure, you can throw color Doppler onto the image to make sure that there's no cord floating around in here. So then you sum all 4 quadrants like they've done here. So it'll be like, 4 centimeters, 5 centimeters, whatever. This one's polyhydramnios, so it's actually very large pockets, as you can see all this fluid hanging out each pocket. And so less than 5 centimeter total is oligohydramnios. That's not enough fluid. Greater than 5, it's not that great, but at least we want 8 to 25 to be really reassured that it was normal. And then greater than 25 is indicative of polyhydramnios. There's too much fluid. So this basically wraps up our OBER evaluation. So if after all this we determine that the woman is in labor and it's time to go, now I'll talk about the progression of labor. The definition of labor is when contractions cause cervical changes in either effacement and or dilation. Labor is assessed, like I mentioned, using effacement, dilation, and how the fetus is stationed, so how far down they've descended. And it typically begins between 37 to 42 weeks. That's considered term. Before 37 is preterm, after 42 is late term. And so the labor begins with onset of labor, onset of contractions, and then contractions to complete dilation or effacement actually takes quite a while. This is stage 1. This can take 10 to 12 hours if the woman's never had a baby before, and 6 to 8 hours if a woman has had a baby before. You don't really need to know these numbers, but it's just giving you the broad scope of how long you're going to be waiting for this woman to actually deliver her baby. And then once you hit complete dilation or complete effacement of the cervix, then you are in stage 2, which is actually delivering the baby, actively pushing and trying to get this baby to go. And so this can take actually 2 to 3 hours of active pushing in a nulliparous woman and 1 to 2 hours in a multiparous woman. But just a forewarning, if you have like a G5, P4, that baby's going to come in like 2 pushes. So just be prepared to go fast. Once you've delivered the baby, then you're hitting third stage of labor, which is waiting for the placenta to deliver. Normally it delivers around 5 minutes after the baby, but it can take up to 30 without causing concern. And then the little known stage 4 of labor is when the woman is just hanging out in the labor delivery room, waiting to make sure that there's no postpartum hemorrhage or any other trouble, starting to breastfeed if she can. And then after an hour or so, then they're moved to the postpartum ward, and that's now labor is complete. So we'll start with early labor. So stage 1 is broken up to early and active labor. And so early labor is when the onset of contraction starts, and it goes all the way up until 6 centimeters dilated. If you remember, I said once the cervix is 6 centimeters dilated, that's active labor. So in early labor, the amniotic sac may or may not still be intact. It can take several hours to progress. It can be like 9 hours in multiparous women and 13 hours in nulliparous women. So this woman doesn't need to come to the hospital until her contractions start occurring 5 minutes apart, or they suddenly start to feel a lot stronger. So then once she hits 6 centimeters dilated, this is considered active labor. And this can also take hours to move along, but you'll notice that cervical exam will change a lot faster once you hit active labor, and the cervix will start dilating a lot quicker. Contractions will come more regular as well. Then we hit the second stage, which is actually delivering the baby. So this is once the cervix is 10 centimeters dilated until the baby is actually delivered. And this can take minutes to hours, and this is when you're pushing. And then placental delivery, like I mentioned, can take a couple minutes, or it can go up to 30 minutes. So now, why would you need to use forceps or C-section delivery? Forceps or vacuum-assisted delivery basically helps move a labor along that might not have been progressing otherwise. So this can be due to maternal exhaustion. She's just been pushing for hours. She can't give her full effort anymore. Inadequate maternal effort. So this is like, for example, I had a Charcot-Marie tooth patient who just didn't have good lower extremity muscle strength and pelvic floor muscle strength, so she couldn't push well. You'll also have less rare genetic diseases that cause this too, but that's just an example of someone who can't give full muscle effort. And then also, if you need to avoid maternal Valsalva, so if they have some sort of heart defect or something like that that you want to avoid putting too much strain on the woman's heart by making her push for that long, you can also use vacuum-assisted or forceps delivery. This can also be used when there's fetal indications, so if there's non-reassuring fetal heart rate tracing that does not warrant immediate C-section delivery, if there's prolonged second stage of delivery, or there's failure to progress of the delivery. So if the labor goes on for like more than 4 hours and the baby hasn't moved or the baby has not been delivered, then we start to think of other ways to get this baby out. Indications for C-section delivery are a little bit more expansive. The number one thing is non-reassuring fetal heart rate tracing, and malpresentation. If the baby is breech, that can be another reason to do a C-section delivery. Cord prolapse, so like I mentioned, if the cord falls underneath the baby's head into the vagina, or basically blocking the baby's descent. Failure to progress in labor, failure of forceps delivery. Placental abruption, so this is when the placenta shears away from the endometrium, and so there's bleeding or there's a hematoma forming. This is an emergent C-section delivery. HIV positive mother, this is not an emergent delivery, but this is just if you know you have an HIV positive mother, then you can schedule a C-section before labor occurs. If labor actually has started, and especially if the bag of water has broken, then there's no really reason to do a C-section delivery because the fetus has already been exposed to the mother's HIV. Also, another reason for C-section is if they've already had a C-section in the past, and TOLAC, which is trial of labor after C-section, is not indicated. Just for terminology's sake, if a TOLAC succeeds, then it's called a VBAC, a vaginal birth after C-section, and so you might see that written on patients' histories. And then active genital herpes infection can also warrant a C-section. So postpartum care, I'll go through this very briefly, but basically a typical postpartum stay is 2 days for a normal spontaneous vaginal delivery. That's NSVD. You'll see that 1,000 times written over, normal spontaneous vaginal delivery. And a C-section is 3 days. The postpartum exam basically looks at how well the uterus is contracting. You're feeling for the top of the fundus in terms of where it is with relation to the umbilicus. Normally, obviously, during pregnancy, the top of the fundus is super high up underneath the diaphragm, but it contracts really quickly. So on postpartum exam, we want the fundus to be below the umbilicus. You also examine their pads, if they have any bleeding and what it looks like. Normally, bleeding postpartum is okay, but we want to make sure it's not hemorrhaging. The bleeding should start to get paler as the days progress. This is called the lochia, and this is just the bleeding that occurs after pregnancy. And it shouldn't be malodorous. If it's malodorous and, discolored, then this might be a sign of endometritis. And then another thing to assess is breastfeeding, how well the woman is handling it, how the baby is latching, if she's having any difficulty with lactation. Remember that it can take like over 24 hours for milk to actually come down, so they might have some frustrations with that, and it's just encouraging them and being supportive. So that was the first of my OB-GYN Success podcast. So hopefully that helps and didn't bombard you with too much information, but just wanted to wish you the best of luck on your OB-GYN rotation.